Hi, welcome everyone. Thank you for joining us. You know by now that iEcho is hosted by the Gastro Foundation in association with Project Echo from the University of New Mexico. And these are weekly sessions held on the Wednesday with various topics. The chat is open for questions. Essentially, this is the lower GI session that we're running today. But I think this is quite an exciting discussion, and please feel free to contribute, ask questions in the chat. Ray, if you put up your hand, unmute and chat, because I think we got an interesting case. And this is a real life situation. So, this is a case that myself and Dr. Birkenfeld were involved in. And the reality is that we actually don't know the answer. And this is the best way to actually approach this patient in a multidisciplinary team meeting. So we've essentially we've gathered the troops because I needed some help in deciding how to manage this patient. So we've gathered some experts today, and hopefully everyone can contribute and share their insights. We've got Prof. Thompson. I think everybody knows him. I don't think he needs any introduction. We've got Sarah, who's a pediatric gastroenterologist. Tim, I think most people know Tim as well. He's also a pediatric gastroenterologist. And then we have Julia, who's a pediatric colorectal surgeon. So without further ado, I'm going to let Sarah open up the case and initiate the discussion. And the aim is for us to have a bit of a discussion at the end, come together, share thoughts, share ideas, and see what's the best way to actually approach this case. Thanks, Sarah. I would just like to just give everyone a heads up as well. Um, Sarah has kindly agreed to continue the talk, even though she's suffering from a laryngeal nerve palsy. So please excuse her voice. If you can't, you just let us know. We will try and address that. But she is struggling with her voice, and despite that, has kindly agreed to go on with the talk. So please just bear with her as well. Thanks, Sarah.
Thanks, Vix. Hello, everybody. You get to hear my sexy voice today. I hope you can hear me nicely. If you can't, just shout out and Vix can take over or try and interpret a few things for me. Um, so Vix gave this talk the title, A Multiverse of Questions and the Inevitable. But is this the end game? And I think that's a little bit cryptic to start off with, but let's go through the case and we can trail back to the title at the end. Okay, so our case presentation is my little JH. He was a 10-year-old, which came to see me in grade 5. And actually, he was referred to me by Dr. Lala. Um, the reason he was referred was that his mother was a patient of Dr. Lala's and was being treated for familial adenomatous polyposis. And according to little JH, he was overall not too unwell, but did have some abdominal pain that had been on and off, and had one episode of bloody stool in the last 2 months, and it was associated with diarrhea. So, just in terms of the family history, the rest of his history was relatively insignificant, but his mother had been tested for the APC gene and had previously had a colectomy with a proctectomy. She has an ileal pouch anastomosis, and what had happened was that she was referred to Dr. Lala for extensive polyp resection. And just out of interest, on the maternal side, the grandmother had colon cancer, and the paternal aunt suffered from pancreatic cancer, but there was nothing else significant there. So I've just put a copy of her genetic results. So she's female. I've just blocked out all the other identifiers, and we've got the variant in the APC gene, the 1666C4T mutation, and it evaluates. And I'll go through the rest of the report just so you can kind of see how it's reported. But essentially, little JH was completely healthy on examination. Skin, particularly, was fine. Abdomen was nice and soft, no masses, nothing to worry about. But he did come to me with his test results. So he was 10 years at the time, and he had exactly the same mutation as his mother had, which was obviously a targeted test that they had done. And the decision that we made was that we should, based on the fact that he was 10 and he had a confirmed mutation, but he also had symptoms, was that myself and Dr. Lala would proceed with screening gastroscopy and colonoscopy. And we'll discuss whether that was the correct decision or the wrong decision to make. I think we're really just open to the criticism. My disclaimer, I think, is as maybe other pediatricians, is that we don't just see these patients routinely. So our management is very literature based and guidance based, and certainly open to criticism or change. So just to understand the mom, so her course was quite a significant course in that not only did she have the colectomy, but she had significant duodenal polyps that were previously difficult to manage and were she was being planned for a Whipple procedure. And when she went to see one of the surgeon for a second opinion, before he booked her for the Whipple, he suggested that we try an endoscopic approach to try and clear these duodenal polyps. And the biggest concern was quite a large polyp that there was fibrotic change. And so whilst previously they weren't able to manage it, she was by endoscopy able to get that polyp out. And so she, for all intents and purposes, is being managed now. Just to go through the genetic mutation here, that based on the fact that it's in both the mother and the child, and that there has been a description of this gene associated with FAP, we call it a pathogenic mutation. But there are many different mutations which may cause FAP, and as well as some new mutations that haven't been described. And I'll get a little bit into that in a little while. So I've just got the gastroscopy pictures that we just took photos of. So for some other reason, I think we weren't planning on presenting, or at least I wasn't planning on presenting at the time. So I didn't have the video on then. But you can see this was a duodenum, and there was quite a number of polyps. Well, let's just call them polyps for now, both in the duodenum D1, D2, and Puller here looked nice and normal. But he also had some funded gland polyps, which looked macroscopically relatively benign. What I want Vix just to do now is if you can play the video for us.
Absolutely. I'm just going to take over the screen sharing.
Okay.
And what I'm essentially going to do is just show you two videos. I'll show you that the gastroscopy. That's mostly pictures, and I'll show you a video of his colon because I think that's will help drive further discussion as well. Just shout if you can't see it. Can you see my video?
Yeah, we can. I can.
Yes, you
Perfect.
can.
Perfect. Thank you. So this is his duodenum, and again, you can see that there's multiple polyps. There's one over there. There's one over there, and probably head in the order of between 20 to 50 polyps in his duodenum. He does have s- probably subtle adenoma on his ampulla as well, but very small. And there you can see polyps in the background. So he had quite a number of duodenal polyps. And remember, he's age 10. And this was his mum also had quite a large number of duodenal polyps. So proceeded to resect some of them, the bigger ones, also to gain histology so that we could classify him further with regards to a Svingelman classification. And I just wanted to show his stomach as well. So in his stomach, you see that there are a few, but not too many small fundy gland polyps. I think there's different phenotypes of FAP, and you do get patients who have carpets of fundy gland polyps, and then you get patients who don't have as many. His mum certainly doesn't have a carpet of fundy gland polyps. She does have some, but none were too concerning, and they weren't full on carpet. So we then proceeded to do his colonoscopy. And really, the reason that we actually did his colonoscopy, he's quite young. And even though he was positive for genes, is because he had that single episode of PR bleeding. So this is his right side. You can see a polyp there. This is essentially retroflexion in the ascending colon. And I do a bit of a pull through so you can see a bit of his transverse colon. And you're seeing a number of small polyps there, not too big, but you can see that there are some polyps in his transverse colon. I then straightened out the scope, went back into forward view, and advanced the scope again into the cecum, just to give an impression about the load and the burden of polyps on the right-hand side of his colon. So that's going back into his cecum. That's his cecum with his appendix there, and you can see a few small polyps on the right side. I then wanted to show you the left side, which I think is more significant. So this is withdrawing along the descending colon. And again, you see a number of polyps, and if you look at them carefully, they look like adenomas, and none of them had particularly concerning features with regards to demarcated areas or concerns for malignancy. But what you do appreciate is that the left side of his colon, the burden is probably a bit higher than the right side of his colon. So if I had to guess, I would say he had in the order of 50 to 100 polyps, not thousands, and a few more than 10 millimeters, but the majority less than 10 millimeters. Now, the issue was the PR bleeding, and I'm just gonna let this play for a few seconds because I just want to show you something that I think was significant as well. So that's his left side again. Let's speed that a little bit up. Okay, so there in his sigmoid, and that's where you classically find these guys, you see quite a big pedunculated polyp. And to me, I thought that that was the most likely source of his PR bleeding. None of the other polyps looked particularly high risk. So we essentially proceeded, I resected some of the larger ones, the ones that were more than 10 millimeters, and most certainly proceeded to resect the pedunculated one because I felt it was likely the cause of his PR bleeding. So we deployed an endo loop, which is what you see now in the video. Let's just speed that up a little bit. And then subsequently proceeded to a snare resection. Just of note, and I don't actually have that on the video, is that his rectum was relatively spared. He didn't have a lot of polyps in his rectum. They were very small and just a few, probably around 5 polyps or 10 polyps in his rectum. So his rectum was relatively spared. Okay, so I think that lays the foundation for the rest of the talk. I'm going to stop sharing and hand over control back to Sarah to continue with the rest of the presentation, and then we can have a discussion.
Okay, so thanks, Vix. Thanks for having that video of the upper endoscopy ready there. So you saw those gastric fundic polyps as well as the duodenal polyps. And then I'm just going to share with you the histology here. So the gastric, we just took a little bit of random gastric tissue. He had a bit of chronic gastritis. There was a piece of tissue that was taken around the ampulla, which actually looked to be normal. On histology, and then the duodenal polyps, they were tubular adenomata with low-grade dysplasia and some hyperplastic polyps. So we didn't actually, I don't think we in our minds, Vix, we didn't separate what we thought was more pathological, but there was a mix of the two. And then it was this big rectal polyp that Dr. Lila showed you, that was the tubular villus adenoma with the low-grade dysplasia. But actually, even the smaller polyps also had some low-grade dysplasia, and they were all adenomatous polyps. So Vix, I've tried to keep with the theme of your talk. So to carry on, we went, so, I haven't, like I said to you, I haven't managed a patient with FAP before. Vix was very unhappy to be managing a child with FAP before. So we went to the literature. Done several good guidelines with regards to how to screen and how to manage. But the position paper that the pediatrics gastros use, particularly both in, I suppose, North America and in Europe, are the ESPGHAN guidelines. And there's a full paper that actually goes through all the screening guidelines. So I've kind of leveraged off most of their recommendations, which are evidence-based, and they're very similar to some of the other guidelines that come through. But just to kind of put everyone into the picture, so FAP is an autosomal dominant genetic disorder, hence why the maternal inheritance in this child. And the pathology is characterized by the development of hundreds to thousands of adenomas in the colon and the rectum, but there are also extracolonic manifestations, so clinical examination and possibly referral to other specialities may be needed just for screening purposes, as well as ongoing screening for, as Dr. Lala said, for the rest of your life. So your FAP gene, just need to move, yeah, is located on chromosome 5q21, and it actually acts as a tumor suppressor gene. So it's in the WNT signaling pathway, and that's one of the pathways that's relatively important in homeostasis and pathogenesis and then the development of cancer. So usually you get small mutations, which result in deletions or insertions, and then ultimately a truncated protein. And there's definitely clinical correlation between the site of the mutation as well as the phenotypic presentation, as well as significant number of de novo mutations. So when you see the genetic mutation, it's important to do the screening colonoscopy. But if you pick up a clinically significant polyp burden, it's also important to screen for mutations in the APC gene. So the screening recommendations, and this is really where I think it's important to kind of talk about what we should be doing. And I think, again, open to interjection. The guidelines from ESPGHAN are to screen at-risk children between the age of 12 and 14. And possibly earlier if you know the genetic phenotype from the parents to be more aggressive. So again, remembering a guideline is a guideline, always open to clinical individual therapy. And I think what's important just to mention here, and then I think I'm not sure who was on the call when Dr. Lala addressed the concerns in this particular case, is that in our case, which I didn't highlight in the beginning, was that I'm not entirely sure how much counseling this child has had. It seems that the mom has been tested and counseled, and then the child was tested. But the child himself has not actually had genetic counseling. And after the scope, when I tried to meet with the parents and the child to go through things, the parents met with me via virtual consult with the child not being present. So they have their hesitance around wanting to disclose the diagnosis to the child, which I think we can kind of open up to discussion a bit later. So the predictive genetic testing should start at between 12 and 14, and this really targets a child's ability to be adequately informed and to give adequate consent to this kind of testing. And then colonic surveillance similarly starts at the same age once you know the pathogenic mutation. And you can screen every 1 to 3 years, depending on the adenoma burden. And chromoendoscopy is certainly helpful to improve your sensitivity. So again, the discussions that I want to kind of open to the floor a little bit later is to balance trying to detect early pathology as well as the child's decision-making impact, and then also to not losing contact with the family so you don't see them for 3 years and something happens in that space and time. So the guidelines for your colonoscopy, according to ESPGHAN, is your colonoscopy is really there to detect your adenoma burden, to participate as a tool for the gastroenterologists and the surgeons to time when colectomy should happen. Like I said, routine polypectomy only for the larger lesions bigger than 1 centimeter or 10 millimeters, and then like an outpatient thing, symptoms like rectal bleeding or diarrhea, like a mucosal discharge would warrant an earlier colonoscopy. And really, your histology needs to detect dysplasia accurately. So when you've got many polyps, you can't really adequately say which are cancerous and which are not. According to the National Cancer Comprehensive Care, well, National Comprehensive Cancer Network, their guideline is similar. So again, starting detection between the age of 10 and 15. But just to highlight here, there's not evidence for accelerated cancer development in those first kind of 10 years. So if you have polyps, in your first kind of 10 to 20 years, you don't have accelerated cancer risk, although you certainly have a higher cancer risk than the rest of the population. And the importance here is just continuous screening and following up. So again, we're going to open this up to the surgeons is that when to consider colectomy. So the guideline is a high adenoma burden, so more than 500 polyps that are more than two millimeters, certainly presenting like a carpet of polyps. Adenomas that are more than 10 millimeters or high-grade dysplasias, and symptoms like rectal bleeding or mucus discharge. And there certainly isn't a fixed age, and I think this is where a team decision participating with counselors, geneticists, the patient themselves, the family, the surgeon, stoma therapist, and the gastroenterologist needs to participate in the decision making. But certainly any signs of high-grade dysplasia needs to be a priority for an earlier colectomy. The options for surgery, and really this is me giving you literature because I'm not the surgeon and don't have first-hand experience. So please, the surgeons can step in with their experience. That your ileal pouch anal anastomosis is really the surgery of choice when you've got significant rectal burden. And that then allows you to take out most of the rectum while still preserving anal function and trying to eliminate as much of the cancer risk as possible. If you think that there are few rectal polyps that you can potentially leave the rectum in, an ileorectal anastomosis may be an option, but you have to continue surveilling this your whatever remains. So if it's your rectal mucosa in your pouch, or whether it's your ileorectal anastomosis, you have to maintain a strict surveillance program so that because the only thing you're removing is not the genetic mutation, but rather the organ that is at risk for the cancer. And there's certainly going to be some tissue that remains that can be at risk. Now, this is interesting, and I think Vix and I jumped the gun here a little bit with the upper GI surveillance. Can you hear me?
يعني عندها خطة وخطتها دي يعني إنها كان ما بتتجاوز ال5 سنين، لكن جات لقيت إنه هو زول ده رجال طيب يعني.
Vix, I don't know if you can silence everybody.
Yeah, go on, Sarah, it's fine.
So actually the guidelines for the upper surveillance is to start in your mid-20s, or if you have a family member who presented with advanced duodenal disease 5 years before they start their age of diagnosis. So we were a little bit early, but I think we were kind of only trying to get a handle of this child and make sure that we weren't missing anything. Of course, earlier for any patients, earlier gastroscopy needs to be done for an unexplained anemia, or if there's a suspicion in the family history. And then what you expect to find is the fundiclam, them polyps, but the importance is your duodenal adenomas, particularly around your ampulla. And you want to really evaluate them as well as you can, sampling. Certainly the polyps that are bigger than 10 millimeters, the big gastric polyps, and then really polyps that appear as big mounds of tissue. You want to try and remove all the antral polyps because there's a high risk of adenomas in those. And then surgery, again, open for discussion, but the idea is, I suppose, with advanced endoscopic techniques to try and avoid surgery, which usually is quite drastic surgery at all costs. But you do need to monitor the progression, and that then becomes more significant in the adult patient population, because really high-grade dysplasia is not common in children at all. So we tend not to see it, but we become part of the early surveillance team. So like Dr. Lala mentioned earlier, there's some literature that allows us to guide our surveillance, remembering that in children particularly, I suppose in adults, a scope is a risky procedure. So it's a risk of an anesthetic, it's a risk of the scope itself, bleeding, perforation, etc. So as well as the psychological and social implications of repeated scopes. So we kind of want to have a bit of a guideline with how often to do these scopes. So really, there's a scoring system called the Spiegelman classification, and that allows us to grade our findings into a stage. It's naught, stage 1, 2, 3, and then a stage 4. And depending on what stage you land on, you kind of a minimal or no risk for high-grade dysplasia versus a severe risk and a high risk for potential cancer, which would then guide any surgery or any further or more frequent monitoring or endoscopic interventions. So essentially, you get a score out of 3 for each of the 4 groups, so number of polyps, polyp size, the histology, as well as the dysplasia, so low grade or high grade, and then you score out of 12. So between 9 and 12 points is a stage 4, 7 and 8 would be a stage 3, and a stage 2 would be a 5 to 6 points. So I suppose when you do the scope, when you're trying to make good clinical decisions, whilst it's quite challenging to document all these changes whilst you're scoping, they do have implications for your surgical and screening protocols going forward. So I know, I mean, that's kind of a learning point for myself. I mean, we do need to rescope this little kid at some point with real close attention to numbers and positions and size and where he would fall in from a screening protocol perspective. Really, the screening is all for cancer detection. So this is a cancer mutation, genetic mutation. The role of the gastroenterologist or the endoscopist and the surgeon is to prevent cancer. So from a pediatric perspective, the cancer risk is really rare under the age of 20, but we do know that by by your mid 50s, that your lifetime risk is almost 100%, and your risk increases at an early age the more polyps you have. So we know there's good literature that your prophylactic colectomy in adolescence will significantly reduce your risk. And then you've got to remember your other malignancies. And that's kind of where I said to Vix and the team is where, as much as I'm not like pediatrics will probably be in this country the forefront of extensive endoscopic resection, we are pretty good at managing parents and their fears and their expectations in a bit of a different way. And that's really what the pediatric role in this pathology is, to screen for the other cancers, to educate the parents on their long-term risk, and really just to support the patient and their parents with the associated cancer risk, which is your duodenal cancers really in the older population. Hepatoblastomas can definitely present in the first decade of life. Thyroid cancer when you're a little bit older. And then there's certain CNS tumors that are associated with your APC mutations, and they fall under like your Turcot syndrome and really just other high cancer predisposition genetic syndromes. But generally, luckily, as pediatricians, we can tell the patients that as whilst they're under our care, their risk for cancer is relatively low, which may give them a little bit of reprieve in their early years, but certainly not forever. There is some literature around surveillance with hepatoblastoma. So if you've been diagnosed with hepatoblastoma, should you be screening for the APC mutation? And then should you be screening for hepatoblastoma with, should you be screening for APC if you've been diagnosed for hepatoblastoma? And really, there isn't evidence for screening in either direction because it doesn't seem to change outcomes. Certainly increases parental patient anxiety, and remembering that for children going for like sonars every 3 to 4 months and blood tests every 6 months is not a benign intervention if it doesn't really change the outcome. So some recommendations are to do genetic testing, but really because the overall consensus is only to start genetic testing at the age of 12 to 14, when patients can start to understand the implications of what the genetic test means. Earlier genetic testing is not recommended, and screening for hepatoblastoma with ultrasounds and serial alpha-fetoproteins is also not recommended. The other interesting extrahepatic manifestation is a congenital hypertrophy of the retinal pigment epithelium. I certainly haven't seen it. I'm not sure if anybody else in pediatrics or in the adult medical space has. It generally is found on routine screening. It's mostly asymptomatic, but there is a significant association with the FAP with FAP and APC mutation. So if you're seeing multiple bilateral oval or pisiform lesions, you certainly are obliged to test for an APC mutation. If you see a single unilateral lesion, you don't have to, and that's probably just a relatively benign lesion, but it is one of the extrahepatic manifestations, and if there are multiple, it needs to be screened. So I'm happy to open the floor to discussion. I think from our perspective, myself and Dr. Lala and the team managing this patient is really the discussion on how frequently, based on the maternal severe phenotype, as well as the fact that at the age of 10, this child has had a tubular adenomatous polyp that has caused symptoms, and the fact that he's got probably 100 polyps up in his colon, all of them being adenomas. How frequently should we be rescoping him? And at what point should we be starting to talk about colectomy? Certainly, there is a guideline, but I think the earlier the team is involved in these decisions, the earlier we can make the best decision for these patients. I have got some talking points, but I thought before we go to that, maybe we open it up to some comments.
Yeah. So maybe I can just maybe facilitate some of that. Just to recap, essentially, we've got a 10-year-old kid with positive APC genes. Mum is known with FAP. She's had a colectomy and significant duodenal burden of adenomas. Um, Kid is unaware of his diagnosis. He has not been counseled. There has certainly been no discussion with regards to surgery. And our hand was turned because he now had a single episode of PR bleeding. Multiple duodenal polyps, multiple colon polyps, I would say less than 100, with one more concerning one, which was resected. And as far as I am aware, his PR bleeding has resolved with resection of that pedunculated polyp.
Yeah.
So let's go through it and see if anyone would have acted differently before we talk about where we should head for this kid and what should be our options. So we're quite fortunate because this is a nice discussion because we've got real experts here. We've got a pediatric colorectal surgeon, we've got experienced pediatric gastroenterologist. I came in as the endoscopist to try and see if we can control his polyp burden endoscopically. So Tim, would you have done anything differently? A 10-year-old kid, would you have scoped him or would you have waited? And I think the fact that Sarah showed you lots of guidelines, and there's a whole lot of variation. Some people say start at 12, some people say start at 15. The guidelines with regards to colectomy is quite iffy. How many polyps, dysplasia. And when there's such uncertainty in the literature and the guideline, you know for sure that it's not an easy decision. You know for sure that the literature is scanty and that this is not very common. So none of these guidelines actually give us any clear guidance in this patient. And just bear in mind that the child also is unaware of his diagnosis. Tim, would you have approached it differently?
So I think your hand was forced. He had rectal bleeding, so there was no choice or no question that you needed to scope him. And if you've got him under a general anesthetic, I don't see the extra risk of an upper endoscopy really is very little. So no, I wouldn't have done anything differently. I think you've got a big dilemma as to how to proceed, and maybe we can chat about that. Um, but overall, the literature, and my disclaimer is I'm certainly not an expert. I've never managed one myself. I've co-managed one a long time ago. My feeling is that you do have literature to say that the risk of him getting a malignancy in the next 10 years is very low. So I think you've got time, but I also feel that we certainly need to start introducing this idea to the child and, you know, use the time that you've got to start broaching the subject and um, to get him on board very slowly. And meanwhile, maybe Vikash, you've got a very patient endoscopist to do your annual endoscopies in the meanwhile. I don't know. That's just top of top of my head.
Exactly why I dragged Sarah into this so she can get involved with counseling the child. So I was certainly not the best person for that job. From a surgical perspective, Prof, Julia, do you think our timing of endoscopy, should we have not done the upper scope? Should we have not done the lower scope with regards to just where we are currently? Would you have done anything differently?
I think, okay, first of all, thank you for this. It's very, very, very informative, and really, it's picking my brain so much. So I'm grateful for that, but also a bit ungrateful because I'm picking my brain a bit too much. So you're requiring a lot of thinking from my side on stuff that it's not very frequent to see, as I said, in our field, because it's usually managed later in life. So it's the adult surgeons that manage it. Um, so I think actually what you found is teaching you that you did the right thing. Like I wouldn't have done anything differently. So I think I would probably have scoped, but I'm not sure I myself would have done an upper GI based on the family history of the mom, because I thought it was too early for upper polyps. But I think I would have done the C scope. Um, and yeah, I think you guys did really well, honestly. And yeah, in retrospect, I think you did amazing. Yeah.
Yeah, look, I think we decided to do the upper, and I agree with you because mum has a history of advanced adenomas in the duodenum. And we know that she was booked for Whipple. We managed to spare her from the Whipple
Yeah.
by clearing the adenomas endoscopically, which of course is the best outcome. But we wanted to map out what we're dealing with and wanted to see. I suppose the argument is don't go looking for trouble when you're not get up to deal with it. But we wanted to just because he's got a family history, his mom has quite severe duodenal adenomas advanced, and so we decided to go map out and see what we're actually dealing with. So I think we've kind of explored the multiverse of questions. So that's where the first part of the talk came in. And then the second part of the title was the inevitable. And I think the inevitable, we all kind of know what we're dealing with there, and that's a colectomy. But for me, the question is, and this is really where I'd appreciate some guidance from Prof. Thompson and from yourself, Julia. The question here is, we've got less than 100 polyps. We've taken out the big ones. There was no high-grade dysplasia. We've taken out the big pedunculated one, which seems to have resolved the PR bleeding. Kid is 10. Do we have room to survey him endoscopically? If so, till what point? Should we take the colon? If so, when should we take the colon? So for me, and I had this discussion with Sarah, the question was, I think the inevitable is taking the colon, and we can discuss what type of surgery in a bit, but I think that's the inevitable. But the question is there room to grow him up and survey him endoscopically until then? Should we just leave him until then, let him grow up? Because as far as I understand with regards to FAP, it's not like Lynch. In Lynch, your progression to cancer is rapid. So most patients get interval cancers in 2 years, 3 years. But with APC, it's the APC mutation. It's not the serrated pathway. It's different. So your risk for cancer in FAP is just because you have 1,000 polyps, so not so much that the pathway is as accelerated as it is in someone with Lynch. So the question is, what next? And I'd be interested to get some of your insights, Prof, as well as Julia.
So can I start? I think you really were forced to do the colonoscopy for, as Tim said, if you had undiagnosed rectal bleeding and the family history. But it would be good to have a little bit more information on exactly when, maybe I missed it, when the mother had her colectomy and whether she had any cancers in the colectomy specimen when she had it out. Because I think that would give you a little bit more information. Because you definitely want to postpone and give you time to get to the counselling aspects. Um, and so you're looking for reasons not to do the colectomy. And again, in the absence of 1,000 polyps and the history from the how the phenotype presented to the other family member, that would be a big help. So perhaps you could refresh my memory, or do you have that information?
Yeah, I do. So we don't have all of the information. It's somewhat unclear. Mum is 45. She had a colectomy in 1997. So she was probably around 18 years old, 18 to 20 at the time of a colectomy. As far as I understand, that she didn't have any malignancy at that stage. She's got a pouch and she has been having pouch surveillance scopes, but she didn't present with a malignancy. I'm not sure how she was diagnosed, and she had a colectomy, let's call it in the late teens, around the age of 20. Her mother had a colorectal cancer at age 42. So grandmom had a colorectal cancer at age 42, as far as we know. But again, we're not entirely certain.
And you're not sure if the grandmother had the syndrome.
Not sure. I highly doubt she was tested, at that stage, and I'm not sure at all.
I think that would be reassuring if she didn't have a cancer in the colon specimen, and that that's when you're sort of looking to do the colectomy in this young man, probably between 18 and 22. I would have thought that that's what you want. And obviously, again, I think, the classical pathway for the adenomas is, as you say, it's a 10-year. That's why all the surveillance for sporadic colon cancer is really based on the adenoma, uh, shall we say, timeline, which is thought to be round about 10 years. So again, he hasn't got a cancer already. You've taken out the biggest polyp that was symptomatic. You can still take out anything that becomes symptomatic over the next while. I certainly wouldn't go taking the small ones when you surveil. I think I would have been quite content just to take the one here to make the diagnosis and not take any more. But again, size would have been an influence in what you did. The one you took, it was actually had a stalk.
Yeah, it was pedunculated. It was a tubulovillous adenoma, low-grade dysplasia. So I took off a few others, which I thought were bigger than 10 millimeters. Those
Yeah,
are
sure.
the main ones that we took out. The smaller ones we left in situ,
Yes.
but try and assess it endoscopically and make sure that none were overtly concerning.
Yeah.
Yeah, and I didn't think any were.
So maybe we could turn it over
Yeah,
to
so
Julia regarding
it sounds
surgery.
like
If you
the
tied her
room
over
to survey endoscopically, grow him up, and then potentially go for the inevitable.
yes.
Okay, so I
So
think I need
yes, Julia. What if you get him to 18 or 22 and you've counseled him and he's got an idea of what's happening. What operation would you do for him?
okay, but I need to go back one step. I'm sorry.
Okay.
And I'm going to be a bit controversial, but I think first I need to make a disclaimer because I'm a surgeon, but I don't really like to surge. Okay. So, as much as possible, I try and avoid surgery. Okay. So, don't think I'm one of those that surges a lot. But I think we need to start with the end point, which is what Dr. Lala said, like this is the inevitable, right? So, we are heading there at some point. We just don't know when the right point is. And so, before discussing what type of colectomy, I think it's my question to Professor Thompson is more like, why not now? Meaning, for me, the biggest issue here is that he is 10 and he hasn't been counseled properly. And we don't really know if it's because of the parents that are trying to avoid and protect him, or if it's because, like, we haven't really thought about the fact that maybe a 10-year-old has his own thoughts about what he wants for his future. Because perhaps having seen what happened to his grandmother and to his mother, perhaps he already has some concerns, some questions, and some decisions about his own body. So I think that's the most important thing. We haven't really counseled him well, so we are just speculating about what his thoughts are. But my question is, what is a colon giving us for 10 more years in him? meaning what's the function of his colon other than absorbing fluids, and what is it gonna give us, meaning that we could slow him down with loperamide, and obviously have him followed up by a dietitian. So I don't know what are we gonna achieve by leaving the colon for longer. That's basically my point. And now I'll expand a bit on that by saying, like, there are two described options for the surgery, right? Which is the ileorectal anastomosis, in which he preserved the rectum, but it needs more surveillance, which is probably more indicated in a child like him. And I would go for this one if there are less than 20 rectal polyps. Or there is the IPAA, which is ileal pouch anastomosis. But there's also a third option that we don't really talk about. And the only reason why I'm mentioning it is that it's his age, basically, which is the straight ileoanal anastomosis. It's not very frequently performed in patients with FAP. We perform it very often for patients with Hirschsprung's disease, with total colonic aganglionosis. But that in a 10-year-old, I would probably consider this approach because they adapt much easier. And that's why an approach like this, I would probably consider it in a patient younger. And in an 18 to 22-year-old, I would never offer a straight ileoanal anastomosis. So maybe I'm throwing more fuel on the fire rather than answering questions here. But I don't see anything wrong with him having a earlier colectomy rather than later colectomy, because I think he showed us that he comes from a family in which there was actually a colorectal cancer. His mom had a colectomy at 18, so it's quite a young age. Yes, there were no cancers, but she had quite an early colectomy. He has upper tract disease already, which is usually a sign of a higher aggressive phenotype. And he did have symptoms, which are now resolved after the polyp was removed. But at 10 years of age, already having a PR bleed and upper like epigastric or abdominal pain, he's already symptomatic. So perhaps in this specific case, and also because he's a male, I would be more in favor of a earlier colectomy.
Thank you for sharing that. I'm going to just play devil's advocate, and not because I disagree, but just stimulate some discussion. I mean, with regards to an earlier surgery, so number one, I think the kid has been sheltered, and I don't think it's his own choice with regards to not wanting a colectomy. I think mom and has been through a lot, and she is trying to protect him from that trauma until he might be at a later age to be able to deal with it. That was my feeling. Number one. Number two, I would say quality of life, going through school, passing 5 to 7 stool a day, stigma at school, potential of things like incontinence, bullying becomes an issue. Number three, fertility. Yes, he's not a female, but something to bear in mind with regards to, I mean, you could argue that should these patients be having families and passing on the gene, that's a whole different story. But fertility, yes, he's a male, but with regards to something like a pouch fertility, and just more emotional, stability and being at a better age, or I mean, can he really understand what this involves at age 10? Is he, really of that emotional maturity to be making such a big decision now? And I mean, if you look at the rules with regards to surgical consent, um, he can't technically consent. So again, I'm not absolutely not disagreeing with you. I'm just playing devil's advocate a little bit.
Right, but again, we're making assumptions like they can't give consent, but they can give assent, or they can be against it, and that's telling you something. He hasn't been counseled at all, and then yes, he could be against surgery and maybe or not understanding, but then maybe that means that we can wait. But what if actually he's thought about himself as of a ticking bomb? So, like we're really making assumptions. So I don't think we can decide based on that. That's the only variable which is completely out of our hands, I think. The other one is social, compliance. Yeah, I think the mom brought him to you already, telling you that he was symptomatic, but then we also deal with parents that kind of become ostriches when you give them a diagnosis like this and don't want to know. So are we sure that he's gonna be brought back for surveillances? So I can't know this. I'm sure that you probably know better. You have met the mom, so you probably know better. But that's something else that needs to be kept like into consideration on a decision like this, which is massive.
Yeah, absolutely. No, I completely agree. I think she probably will fall up for surveillance because she has gained some trust in our team, especially considering that she was due for a Whipple and we managed to prevent her from having a Whipple. Prof. Tim, any comments with regards to that?
Vix, can I say something in my
Yes.
soft voice? Oh, go ahead, Prof.
No. I definitely don't want to say anything. I think Tim and you should say things because, I mean,
Yeah.
all these issues are in relationship to consent in a 10-year-old.
That's exactly. So, I mean,
Something is an elective operation with what is a relatively low risk of cancer developing before the age of 20. Not negligible, but low. And again, I'm not an expert on the functional result from pediatric surgery for Hirschsprungs, but I do know that when you give individuals ileorectals, that stool frequency is a real issue, and that if you were doing an ileoanal, there would be a consideration for doing a covering stoma. That brings a whole new set of intricacies into it, and I wouldn't even begin to know how to broach that with a 10-year-old, but perhaps you could give us some guidelines as to how you would go about it. So I think the ball from the questions that Julia is saying are in Sarah and Tim's hands as well as in Juliana's hands.
So I don't know if anyone can see this slide on, I just went through what the laws are in South Africa. Vix, can you see this?
Yes, we can, Sarah. Yeah.
I mean, the law, as I think you mentioned, is that the age of consent is over the age of 12. And I think the question that I have to ask, and I actually don't know the answer, is that if the child is 10, Julia, and the parents don't let you tell them the diagnosis, can you still tell them the diagnosis? Because they're actually not, they're still under their parents' consent umbrella. So I'm not sure if the parents have said to you, we don't want you telling our child diagnosis. At what point do we as medical professionals, when can we supersede that?
I don't know the answer to this, Sarah. I had it twice with patients that had holovisceral myopathies, and like the parents, like I told the parents once and the grandmother in the other instance, and they both said, please don't say that to my child. I'll try and say this at home later on, but I don't want you to be telling them directly. And then at follow-up, well, both kids are now dead, obviously, but they, like, I don't think that they were ever told that it was a like palliative disease, like for palliation. So they were only explained the symptoms, they were only explained the possible surgical options, but they were not told that they were going to die, which is different from this, though, very different. So
Not entirely different, because what we're talking about is a fatal cancer genetic syndrome, which, if we miss something, the child is, if our screening misses another malignancy, the child can die from that. So, I do think it's similar context. I think what we can say is covered by law at the moment under the age of 12. We would need the parents' consent to do any surgery. And based
anything,
on
yes.
the fact that it's
But
not
also a C-scope,
emergency. Sorry?
also a C-scope or a G-scope, anything you need to do on the patient, you need their consent.
100%. Yeah, exactly. But if we were wanting to do a colectomy and the parents wouldn't agree, even if the child wanted it, we couldn't do it because it's not an emergency. I don't think, without trying to go through all sorts of social barriers, social service barriers, which I'm not sure is warranted. But I mean, it's all interesting discussion.
In the interest of time, I just want to take the discussion just to one more area. We just got a few minutes. And so I think it's clear there's a multiverse of questions. The inevitable is the inevitable. And I mean, the last part of the title but is this the end game? I think is pretty much obvious. This is not the end game. There's still a lot more other things to think about, other organ disease, his upper. I've had a handful of patients with FEP, and I really got involved more to manage duodenal adenomas. And my personal opinion with all of these FEP patients was I told them I'm not doing a capsule on you because at some stage you got to draw the line. So you take their colon, his mom almost had a Whipple. Sometimes they get a gastrectomy for dysplasia in the stomach. You do a capsule, you find more polyps downstream. Where are you going to draw the line? And this is not based on literature. I've actually told my FAP patients, I'm not doing the capsule on you. I actually don't want to know what's downstream. If you have symptoms and you need to investigate, then we'll investigate. But just to close, any thoughts with how we should manage his upper GI? I know this, Julia, your expertise maybe more in the lower GI, but anyone in the panel want to just share some thoughts? We did jump the gun, but now we've got the problem in front of us. Should we follow Spiegelman? What should we do?
It's a field of change. So he's in for lifelong surveillance. And once you get to large irresectable, and the problem is that even though you resect quite a number of them now, or even try and resect quite small ones, which will be relatively easy and probably safe, the problem is it's a field of change. And that field of change has to be monitored if you're not going to take it out. There was I was involved with a couple of cases. There were twin sisters who both had FAP, and one of them died from the cancer, and the other had a Whipple and survived the whole ordeal and the colectomy. So I think counseling this young man is 9 parts of the law. And again, Tim's remained silent a little bit regarding this, but I think that's where the crux of this comes. I have a son who has a familial condition, and again, I went through this as parents, a different familial condition, but nevertheless, it has implications for procreation and all sorts of other things related to how he's monitored. So I think having been a parent in that side of it, and we made the diagnosis when he was 1. At least I made the diagnosis when he was 1. So, and he never really was aware of it until he was about 14. In terms of what it might mean for him, not that he didn't know the diagnosis, but he didn't really know what it meant for him. So again, I would come back to Tim. Maybe Tim, as the senior pediatrician, you might
No gold nuggets here, but I think we do have a lot of experience in South Africa at disclosing to teenager, and that's within our HIV field, and not being involved directly. I just know that most of the time these children are not as unaware as we think they might be. And this is a child whose mom's obviously been ill and has had major surgery and now has had a bleed. And I think, yes, he's only 10, but he probably has some ideas that things aren't all normal. With regards to the age, I was just thinking of my own teenagers, and I think they probably would make wiser decisions when they're 10 than when they're 16, but that's an
I agree.
not really helpful. Yeah. So I think we do need to and get counselors on board and make it a family or MDT sort of approach with the family to start informing him slowly.
Yeah, I think this discussion just perfectly sums it up. This needs to be done as an MDT. And that was the whole point of this. And I think it just proved that these patients are so difficult to manage and they should definitely not be managed by a single person. In fact, we could have actually brought a psychologist onto the call, the histopathologist onto the call as well. Yeah, we could have expanded it to the geneticist. And yeah, I mean, it's MDT discussion is really, really, really needed in this thing. So that's why we decided to use the Avengers play, and I felt like Nick Fury putting together the team of Avengers to battle the common enemy. And in this case, it's not tennis, but it's cancer. Yeah, and the inevitable is the colectomy. I just looking at the pictures of Sarah with the perfectly balanced knife, and it for me it just reminds me of a perfectly balanced scope in my hand. And all I want to do is go and resect those polyps and try and save the colon. But we got to yeah, understand our limitations and come together and discuss these patients as a team, and that's the best way to manage it. So from my side, I just really want to thank all of the panel for sharing their expertise and their time, especially Sarah for pushing through despite a lack of a voice. And yeah, Prof, if you want to have any final comments or would like to close, please go for it.
No. I just want to, if I may, if I can you stop your share, Sarah?
Oh, sorry.
No, not at all. I just want to show you maybe. I just want to see if I can, just for a second. Um, um, Sorry, I didn't seem to. Just tell me if
Um,
can you see this or not?
yes,
Can you
Yes,
see a
we can.
PowerPoint?
Yes, we can.
Oh, okay. Yes. So this is a gentleman I was involved with, and I have some dilemmas with him as well because I left Durban. But he really did have 1,000 polyps. He was 28, and 3 of them were cancers. And this is what 1,000 polyps look like. Unfortunately, he went on to have another 5 children after I left Durban. So my plea really is that I think to everyone around, I think if you have these familial cancers, they do lend themselves to being followed up and the family trees and the genetic trail. And there's a need for a national registry for this. And again, then we can start to get some information. So if I have any pleas, it would be we wrote an editorial on it for Lynch syndrome, but the same applies to FAP, even though it's 1% of the hereditary cancers, because these are very good patients to hone your MDTs and also to improve your surveillance strategies for these patients and make decisions about genetic testing, which is now available, who to do it on, and what's the most cost-effective way to do it. So that's all I would like to say. I think there's a need for a national registry on these types of syndromes, and
yeah.
hopefully some of the geneticists are the ones that should hopefully drive that with clinicians like us putting into that.
Yeah.
And I know that's been
On
successful.
that note, sorry to interrupt
Yeah,
you. There's a question in the chat, and I think it relates to what you're saying as well. And I'm not sure if someone wants to take it, maybe Sarah. And I think it's a very good question. It's the question is what happens to a suspected case where genetic testing is not available for the child. So in this case, we knew upfront that he's positive. What if we didn't?
So if you had a parent who was diagnosed with FAP or suspected of FAP, I'm assuming if the parent had genetic or didn't have, you would treat the child as being at risk and you would do that, you would follow your screening scopes exactly as you would, assuming that the child did have an APC mutation. And I think, if I'm going to be mistaken, I'm going to have to check this up, but you continue screening every 1 to 3 years, depending on what you find, until a certain age. And I just have to check what that age is. I think it's probably like mid-20s or 30s. And if you found nothing in that period of time, you can stop your FAP screening, but then continue with your standard colorectal screening protocol for adults. But you would, if the parent was affected, you would be safest to assume the child being affected and follow a colonoscopy screening protocol for that.
Yeah, completely agree. Do you want to wrap up, Prof? I think we already are over time.
Well, it remains for me to thank everyone and for Vikesh for putting the team together and what little part I played in it. It's been a while since I've seen these patients, but I have in my career seen quite a few of them that I've been involved with. And they are difficult problems, and our systems need to be better in place to deal with them, in my view. So thank you everyone for doing that. This is recorded, so those of you who haven't seen it or who other members of the team suggest that they should see this, because I think it's a valuable insight into the whole problem and a really nice summary of the dilemmas when you diagnose this in very young children. So thanks again, and I think next week there's another, I'm not quite sure what's next on the agenda, but there will be an upper GI one, which I think is going to be on manometry of some sort. And we'll see when the upper endoscopy turns its head. So thanks again, and good hunting, and have a good evening.
Thanks,
Thank you.
everybody.
Thanks.
Thank you.
Bye.
Bye.